Hi, everyone. Welcome to another Monty Hart lecture. We have the great honor today to have, after Thanksgiving, Sarah Rinehart, who will be speaking about AI plaque analysis, the paradigm shift in CAD management. I think this is a very important topic, one that we're very passionate about, and we think that this can significantly impact patient care. So we're really happy to see this lecture. And Sarah has been doing amazing work recently, and it's a real honor to have her here today. So she went to college in West Virginia, Wesleyan College, then went to med school in Marshall University, where she also completed her residency and cardiology fellowship. She completed an advanced imaging fellowship at Piedmont Hospital in Atlanta, Georgia, where she worked for 13 years there. And during that tenure, she co-founded the Women's Heart Program, and she was also director of Advanced Imaging Fellowship and medical director of CT and MRI. She then moved to Charleston, West Virginia, where she currently is in 2020, where she started as associate program director of the fellowship. Now she's the program director and the medical director of Cardiac Imaging Center for Cardiovascular CT and Prevention Clinic, an area that I think is great to mix together. She's also currently the co-national PI on the site registry together with Leslie Shaw from Mount Sinai, where they're assessing the management changes on coronary CT versus stress testing on how plaque imaging informs and changes the provider management. So thank you again for taking the time. We're very excited to have you here and looking forward to your lecture.
Yeah. Thank you so much for the opportunity to speak today and for taking your time right after Thanksgiving. My disclosures are as follows. So, when we look at the AHA Presidential Advisory, the forecast of the burden of cardiovascular disease and stroke can be quite daunting. There's a significant rise through 2050 when we're looking at all forms of cardiovascular conditions. When I'm looking at my patients that I'm seeing in clinic, my first question is, number one, does my patient have coronary artery disease? And if so, how severe or extensive is that disease process? So the first thing we have to think about is, why do we want to do coronary CT first as a pathway at our institutions? And when we look at invasive coronary angiogram, we note from this study from Patel that there are a high proportion of patients with no significant CAD on angiography. And in fact, when you look at it, there's a poor yield of non-invasive testing because 2/3 of the patients who underwent left heart cath had no obstructive disease and 40% had no disease at all. So when we're looking at non-invasive functional tests, I still think they all have their utility, but we have to recognize the problems that they may occur when we're taking care of patients. So 55% of those imaging studies may have false positives because we know that they've already had no obstructive disease on their heart cath. But in the opposite end of the spectrum, we have about 20 to 30% false negatives where patients are sent home with undetected coronary artery disease. So when we look at functional testing, which is our stress testing arm, what you see is if something is normal versus mildly abnormal, the risk is inherently the same. And part of the reason for that is we are not identifying non-obstructive disease on those normal patients. Whereas with CT, with anatomic testing, there's a very clear gradation. So normal patients have very low risk of events for 36 months out. And again, mild, moderate, and severely abnormal cases have a very stepwise gradation in the risk of events going forward. So when we're looking at the DECIDE registry, we really wanted to understand the impact of CV imaging, whether it's stress testing versus CT, but also the advent of plaque analysis and how is it utilized in the real world. So the first thing I want to do is take a look at stress testing versus coronary CT. And we actually presented this data at TCT just last month. What you see is that the stress arm of the patients, the demographics, the patients are typically older. And again, it's a very wide, diverse group of patients. But when you look at the stress arm, the patients are significantly older, they have more anginal equivalent symptoms, and they are at overall higher risk. And specifically, if you're looking at the prevent score, our stress arm had 11% risk versus 7% in the CT arm. When we looked at change in medical management after stress testing versus CT at 90 days, what you see is there was escalation in therapy in both arms, but it was much more marked in the CT arm, which is visualized in green. But what you also see is that there is a de-escalation of preventive therapy in the stress arm, which is what we thought was more remarkable and surprising, especially given that this is a higher risk group of people. So when you look at the percent of patients on lipid-lowering therapy at baseline versus 90 days, again, CT, when you look at it at baseline, had less patients on lipid-lowering therapy, but it was a lower risk cohort. But what you see is in the follow-up, right? When you're looking at the follow-up, much more patients were actually on therapy in the CT arm versus more prevalent patients in the stress testing arm were on it at baseline, and you can see that de-intensification of therapy. So when we are adding new lipid-lowering therapy, which again is much more common in the CT arm, although it is present in the stress arm, what you see is that we're actually intensifying more with high-intensity statin therapy. But when you're looking at that stress arm, you're seeing 6% of those patients in the stress arm actually had therapy discontinued. Some of it was high-intensity statins, moderate intensity statins, or maybe perhaps even PCSK9 inhibitors. So when you look at the baseline LDL, this is CT in the green compared to stress imaging on the purple in the right. Again, the LDL at baseline was higher in the CT arm, lower risk cohort of patients, so it makes sense. But when you look at 90 days afterward, they're about equal. So even though the numbers aren't significantly different between the different modalities, you actually have better control in a lower risk group with a CT arm. And you can see there was much more intensive change in lipid lowering parameters such as LDL at 90 days. So all of this kind of goes to support why we use chest pain first, because it helps to, number one, diagnose coronary artery disease, but also to guide treatment decisions in order for us to treat patients appropriately. What we see and what we have known for a long time is that aspirin and statin use increased with after use of coronary CT. But what you're going to see is in the yellow, it's much more prevalent when the disease is more obstructive in nature. In the same way, statin use is sustained after 5 years from coronary CT, but again, it's only maybe in about 50% of those patients. So it really shows us that we have more work to do. This is just one trial that shows that for over 4,000 patients, when you're looking at a CT guided arm compared to standard of care arm, which is stress testing, there was 41% less MI or death in the CT guided arm. Scott Hart, this was published earlier this year and showed that even after 10 years, a CT guided arm had sustained reduction in coronary heart disease death or non-fatal MI. And a lot of this was felt to be because of improved cardiovascular disease preventive care. So what is attainable with CT first and the use of artificial intelligence? Number one, we can use such products such as Roadmap to really identify presence and severity of disease to help our readers. The FFRCT analysis really helps us to determine, does the patient need to go to the cath lab versus medical management? And the Plaque analysis, as of right now, can actually inform medical management on a personalized level. And coming soon, you may actually have a PCI planner where you can use that plaque information in the cath lab as well. So when you look at the layers of evidence, it is quite profound, both in CTA being incorporated in both the European as well as ACC AHA guidelines for stable chest pain. For the use of FFR, there's multiple trials, and these are the most major trials, really showing the benefit of using FFRCT and getting the right patients to the cath lab. And we're going to present the more plaque analysis registry findings as well as decode findings throughout this talk. So, why FFRCT? We're going to talk very briefly about this because plaque does matter when we're looking at FFRCT. Because, from a pathophysiologic point of view, to have the full picture, you need to know anatomy as well as physiology. And coronary flow is not just determined by the stenosis, but also by the plaque type and the plaque burden, as well as shear stress. So this really shows us that when you use FFRCT, it's much more predictive than PET, coronary CT alone, or SPECT for the definition of FFR-defined vessel ischemia. This is very important, especially when you look at the guidelines. It's saying it's appropriate for 40 to 90% stenoses. And again, why is that broad of spectrum? Is that 20 to 40% of severe stenoses are actually non-obstructive and just need medical therapy. And 40% of the patients with mild disease in the LAD actually may have a significant stenosis. The reason I'm bringing up FFRCT is it can be very important with high-risk plaque findings to really look not just at the lesion-specific FFR, where less than 0.8 is significant, but also potentially to look at this delta FFRCT, where you calculate the change in FFR from proximal to just distal to the stenosis. This is especially true in the left main and proximal LAD. So when you're looking at when you get in that gray zone of 0.76 to 0.8, although it is appropriate to go to the cath lab, you're going to be more likely to look at those patients with that gray FFR in that 0.75 to 0.8 zone whenever there's high-risk anatomy or high-risk plaque features or that delta FFR. So plaque features that are high risk, especially if it's proximal vessel with a distinct change of more than 0.12 in that delta, it's very impactful. So why do we want to do plaque assessment? So first of all, there's a lot of limitations in ASCVD risk scores, and that not all include family history. They may not accurately assess risk in all ethnic groups. And it's really based on risk factors at a single point in time. And we may not assess the risk of other events such as PAD, heart failure, or revascularization. And thus, we still need imaging for more precise risk prediction in the future. So when we think about ways we have really historically changed our medical therapy, it's based off of a population-based model, such as the ASCVD risk score or the PREVENT risk score, which is we're going to see a lot more of in the coming year with new guidelines. But we also have the potential to change the individual patient's management based on their risk, but also personalized medicine when we're looking at their plaque volumes. Calcium scores are extremely important in the asymptomatic patient population. And one of the things we have to remember is that it only occurs in atherosclerosis, and the calcification is only 20% of that total plaque. So typically, on average, there's 20% calcium to 80% non-calcified plaque. So the reason we use these calcium scores is to reclassify patients to a higher risk in order to guide treatment decisions. But there are limitations in that we really don't know how much non-calcified plaque is present. Are there other high-risk plaque findings? And we can't use follow-up calcium scores to guide our effective therapy because we know the calcium score will increase, but is that disease stabilizing? Or is it actually rapidly progressive? And we really don't have randomized controlled trials showing if there are improved outcomes with its use. So we have a plethora of new medications that are on the market, and we've also seen significant changes throughout the years with our guidelines. And I'd like to talk about the lipid guidelines in that We went from target-based medicines with options of less than 70 for the LDL and higher risk patients in 2004, where we then switched to an intensity-based model where we say high intensity. Really what we need is to combine these, and that's what the newer guidelines really recommend, is not just a target, but also to get that 50% reduction in your LDL cholesterol. And in 2022, for very high risk, it changed the option to less than 55. So, despite all we have done, there's been an increase in cardiovascular mortality, regardless of the medications, the imaging, the new risk scores. And a lot of this could be due because of the aging population. Diabetes and obesity are on the rise, but we're also seeing an increased survival from ischemic events. And thus, we have a larger patient population with heart failure and arrhythmias. But we've also got confusing guidelines, and it's hard to keep up with everything, especially as a PCP. This is a very important concept. And when we're talking about the outcomes of DECIDE, I really want you to think about this rule. We know from randomized controlled data that for every 40 milligrams of LDL reduction we can reduce cardiac risk by about 20%. So this is extremely impactful. And we know that the lower LDL we achieve, the more likely we are to have improved events. From the Scott Hart trial, as well as the confirmed trial, we actually can see, whether it's women or men, that non-obstructive disease matters, because we start to see increased events in 4 to 6 years with that non-obstructive disease. Yet what we also know from this trial published in 2021 is that about a third of patients who were intermediate to high cardiovascular risk and had non-obstructive disease, they were not on a statin at all. On the flip side of that equation, we can look at the Gould and the Santorini registries. The Gould registry is a US-based registry which has our highest risk patients, those who've had strokes, heart attacks, or been revascularized. And 2/3 of our patients who are our highest risk remained at an LDL of more than 70. Now, the Santorini registry, which is a very similar kind of look of a registry in Europe, had similar findings where 73% were missing their LDL goal. And they felt a lot of this was because of, number one, inadequate risk classification, and number two, underutilization of combination therapies. So when we're thinking about those two problems, we really tried to think, when we were creating the Plaque workflow, how can we identify risk on a personalized manner and teach physicians and APPs, primary care physicians, how to utilize combination therapies more effectively. So we have to have a shift with plaque analysis from going beyond treating the disease in the lumen to using plaque analysis in order to adjust medical regimens on a very individualized basis in order to prevent events. So first of all, you have to have a very reproducible product. So when you look at the REVEAL Plaque study, there was 95% agreement with IVUS in quantifying and characterizing coronary plaque, not just with the total plaque volume, but also with calcified and non-calcified plaque volume. And since this has been released and the product has been available, we're now on our second generation of plaque product. In addition, nomograms can be very helpful. So there is plaque volume stratification by both age and sex, although not with ethnicity. We also know from Michelle Williams' trial that non-calcified plaques, especially when they had that low attenuation plaque, can really matter. And she found that when the low attenuation plaque was more than 4% of that total plaque, the patients were at 5-time increased risk of fatal or non-fatal MIs. Now, this is very important, but we still have a lot to learn. Is it more of a 4% threshold on a total volume standpoint, or is it more impactful if it's more localized? I think those questions have yet to be answered. So then we tried to look at how are we utilizing plaque results. So we had this DECODE trial where we had 3 physicians who were all CT readers, as well as who were very prevention oriented, and we looked at a CT report, and we chose medical stages based off of the Freeman paper. And what you're going to see is we really started patients on stage 2 medical therapy, which was aspirin and high intensity statin therapy. Then we had the plaque analysis revealed to us, and we said, okay, are we going to de-intensify therapy, which we did in a very small number of patients? Are we going to maintain it, or are we going to intensify it? So 2 out of 3 patients had a refined management plan, and most of that was for intensification of the patient care. Now, trouble with this is, number one, we had no financial obligation, and we're all very obviously CT as well as prevention enthusiasts. So the question is, how do we teach people what we learned in the real world, and how is that going to affect change in the future? So it's important to know what data we have available. So when we started this trial, we knew that total plaque volumes of more than 100 helped to reclassify patients from intermediate to high risk. We also did a retrospective look in the advanced registry, and those with plaque volumes less than 100 had 0 events. We can also tell you that when the plaque volume goes over 238, or think about it, 250, you had a significant increase in the hazard ratio, which helps to reclassify patients to more of a very high risk category. So we had an expert consensus where we had experts in prevention who also had a lot of CT experience. We looked at this and we've decided to stage it with mild, moderate, severe, and extensive plaque volume stages. The total plaque volume of less than 100 was mild, 100 to 250 was moderate, 250 to 750 severe, and greater than 750 was extensive. When you had more than the 50th percentile, or you had risk enhancers, which we'll talk about in a minute, we said we really want you to go to the next stage of therapy, because that's what we do in the preventive world by the 2019 prevention guidelines. We worked to highlight appropriate lipid biomarker goals, and we worked with the NLA president on looking at these goals relative to the plaque volume stages. And we chose to highlight all of the options of drugs with proven cardiovascular outcomes, which you could use to improve the disease burden and complications in your patient. Now, we're not telling you what to use. We're just saying these are the drugs that could be useful in your patient, and to think about using them in a combination of ways. So the Fish and Chips registry then actually looked at these plaque volume stages and basically validated them. And what you see is, for higher total plaque volume stages, they were associated with higher cardiovascular event rates that remain significant even after adjustment for risk factors, stenosis, as well as FFR. And you can see there's a very clear-cut increase in risk of events according to that total plaque volume stage. Now, one of the things I want you to look at, these are patients who were symptomatic with coronary artery disease. And again, with a plaque volume of more than 750, the risk was 11%. But when you looked at patients with peripheral arterial disease, and you're looking at asymptomatic patients, it can be helpful in this very high-risk cohort, because there's a 5-year mortality data, and we just looked at less than 250, 250 to 750, and more than 750. And when you look at that total plaque volume in these asymptomatic high-risk PAD patients, the risk went from 11% to 44%. And again, you can see here that all-cause death in this high-risk patient population did increase by the total plaque volume, but also when the FFRCT was decreased. So when do we adjust to that next stage? You could use CT risk enhancers such as proximal location, high-risk plaque, or multiple segments being involved. You can look at the 2019 prevention guidelines and say a persistent elevated LDL persistent elevation in triglycerides or inflammatory markers, or presence of elevation in Lp(a), or patient risk factors such as family history, chronic kidney disease, metabolic disease, unique conditions to women, and inflammatory disease or ethnicity. So I'm going to walk you through a case. This is one of my patients, 71-year-old, hypertension, hyperlipidemia, diabetes, fatty liver, and statin intolerance, and he has family history. So already you can see he has risk enhancers with diabetes as well as family history. He's had a prior negative workup, and he is statin intolerant. His blood pressure is controlled. He is mildly overweight. He's on good blood pressure medications as well as aspirin. He's on metformin, but again, no lipid lowering therapy. And when you look at his lab values, he's got a metabolic milieu with elevated triglycerides, a low HDL. His LDL was unable to be assessed because of the triglycerides, and his diabetes is uncontrolled. Now, this is the first time I see him. He's symptomatic. I sent him for a coronary CT. Now, again, we talked previously about the limitations of calcium scores. If we were just to look at this patient's calcium score, it's fairly low. His percentile is also low. But when you look at the coronary CT, you can see this a lot of non-calcified plaque burden in the right, but you see sequential lesions in this left anterior descending artery, mild disease in the left circumflex, OM, and diagonal. Now, this roadmap analysis, you can see that this is read as severe stenosis. This is moderate stenosis. And again, you can see very low attenuation plaque, positive remodeling. Here's spotty regions of calcification. So a large non-calcified plaque. These are high-risk plaques on CT. From the FFRCT analysis, you can see that both of these lesions are significant. The absolute FFR is less than 0.70. And so it's thus is very important to note this patient does need to go to the cath lab. But when we look at this plaque, I think it's very important. So his total plaque volume was 394. That puts him in the severe stage of plaque. But when you look at his plaque breakdown, remember I told you 20% of plaque should be calcified versus 80% non-calcified, and more than 4% low attenuation plaque is considered high risk. So he has 97% non-calcified plaque and 7% low attenuation. So his burden of non-calcified plaque and low attenuation plaque is much out of proportion to the expected values. And this is despite having a low burden of plaque for his age. So it's important not just to look for advanced plaque for the age, but the type of plaque that and the kind of plaque that you have. So if we're looking at these medication recommendations, what we would say, he is severe, but what we would do is we would go to titrate because he has diabetes and he has family history. So we're going to say his LDL goal should be less than 50 or as low as can be achieved. And all of these therapies could be potentially important to get him to goal. So when we looked at him, what did we do? We titrated his anti-anginals and we sent him for left heart cath. We added a GLP-1 for the diabetes. His BMI was high. He's diabetic. He has bad CAD, and all of this, the GLP-1s are shown to improve outcomes. We did add Zetia, and we got PCSK9s approved, and we wanted to repeat the labs. So he had PCI. His symptoms improved after titration of meds as well as intervention. His total cholesterol improved from 249 to 86. His triglycerides decreased by more than 50%. His HDL improved, and his LDL is now 2, and his A1C is now 6.3. Now, do I think that LDL of 2 is too low? No, I don't. But if you were going to stop something, you may want to stop the Zetia therapy. But his triglycerides are still a little bit on the high side. So despite all of this, it's very critical to educate your primary care physicians as well, because when I saw this patient 6 months later, some of these meds had been discontinued. So when we're thinking about the EMERALD trial, some of the best features for predicting acute coronary syndrome was that delta FFR. Looking at the plaque burden, the total plaque burden, the low attenuation as well as the non-calcified plaque. Those were the predictive features for acute coronary syndrome, much more so than lesion length or maybe the myocardial blood flow per chance. So, if you look at our patient, he had a very high delta FFR, severe stage of total plaque volume with large amounts of low attenuation plaque. This is one of the outcomes trials. And when you're talking to your patients, I literally have that staging algorithm with the goals, but I also have this outcome slide next to me to show them. So when your FFRCT is negative and your plaque volume is lower, you have this negative, which you have a very low risk of events over the next 3 to 5 years. Yet when your FFRCT is negative and your plaque percentile goes above 75%, what you see is an uptick of plaque events in that 3 to 5 year range. Now, when you have an FFRCT that's abnormal, which is true in this yellow and red lines, you have very early events that are present. That's why those patients need to go to the cath lab. But it's also important to change our messaging to these patients because even though we fix these, if you've got a high overall total plaque burden that may still be residual non-obstructive, you are still at risk with a high plaque volume of a downstream event 3 to 5 years later. So the DECIDE registry is really looking at 20,000 patients and how do we really change our medical therapy and what did we learn in a real world setting where we implement the things that I just talked about to you. So we looked at highlighting a CTA that was performed, treatment plan determined, we waited 90 days, then we revealed the plaque analysis, then we looked at a new treatment plan, and then also changes in management. So again, we highlighted the biomarker thresholds in this, and we taught people how to use this therapy. And again, we're highlighting the CT-defined changes were in the first 90 days versus the plaque management changes in the subsequent 90 days. So when we look at the baseline characteristics, this patient has a very diverse patient population. 70% were not African American, were white, but over 50% were female. And again, high risk of disease with 20% diabetics, and again, high prevalence of hypertension and hyperlipidemia. The majority or greater than 50% of these patients had non-obstructive disease by their CT characteristics. When you look at the plaque staging, however, mild plaque volume was present in 25% of the patients, moderate plaque volume in 27%, severe plaque volume in 16%, and extensive plaque volume was actually found in 32% of these patients. So despite over 50% non-obstructive, there was overall a very high plaque burden in these patients. So when we looked at the primary endpoint of the DECIDE registry, what we found is that 51% of patients had a change in their clinical management, whether it was 14% having new labs ordered, maybe to see if they were at goal or looking for a residual risk factor, but 36% had treatment escalation. Now, I think one of the things we have to look at is why did 48% have no change? Maybe the changes had already been implemented in the first 90 days and they had to wait 6 months to monitor the results. So further follow-up and investigation is going to be needed into that. But the thing that is surprising is that when you look at whether it's age, their gender, the ethnicity, their BMI, even the risk factors, what you saw was substantial alterations in management, even across all of these subgroups. So despite the knowledge of the CAD and the risk factors, the plaque analysis still helped to drive clinical action. So when you see, this is by the plaque volumes, but remember I told you you could intensify this stage of plaque volume. So this is the DECIDE plaque stage. on the right versus the plaque volumes absolutely on the left. And again, you see a clear gradation and intensification of therapy, and it's more prominent when you actually look from mild to extensive staging, which is what we like to see when we're looking at clinical research. Now, I think this is actually very impressive as well. When you look at risk factor or cardiovascular risk assessment in the Scott Hart trial, and you're looking at less than 10% versus more than 10%, there was essentially no significant change in the LDL. Yet, when you do a CT-based strategy with no atheroma versus presence of atheroma, you see a significant reduction in the LDL. And this was further enhanced when you're looking at this plaque analysis with further increasing stages of plaque volume. We're seeing increased medical changes in our management. What kind of changes were we seeing? We're seeing addition of new lipid lowering therapy as the primary change, or intensification in 23%. We saw some addition or change in dosage of antiplatelet therapy in 6% of our patients, titration of blood pressure medications and or antianginals in a large proportion. But again, 10% of our patients actually had cardiometabolic medication changes, such as GLP-1s, SGLT2s, metformin, or icosapent ethyl. What we saw in that first 90 days, which is pretty impressive, in just 90 days, we saw in those that had a change in management, the LDL reduced to negative 19 milligrams per deciliter. The non-HDL reduced by 17.5 milligrams per deciliter. And remember what I told you, for every 40 milligrams drop in LDL, you have a 20% improvement in outcomes. And as you can see, again, we know lowering the LDL is better. So one could expect, by seeing this reduction, we could expect a decrease in cardiovascular risk by 10 to 15% potentially. So I'm going to show you one more case. And this is a 52-year-old male with hyperlipidemia. He does have family history, so he has a risk enhancer. He actually has a normal EKG. He had exertional chest pain while playing hockey. His blood pressure is uncontrolled. His LDL is elevated. His triglycerides are elevated. And his A1C is borderline prediabetes. What you can see on his CT is he has a lot of complex plaque in the proximal LAD versus more minimal non-obstructive disease in the right. And again, you can see low attenuation plaque. There looks to be like a napkin ring sign as well. But the FFRCT was negative in this patient, so he needs to be treated medically, despite this being read as a severe stenosis. So here, yellow is considered non-calcified plaque. The blue is calcified. So again, on this plaque algorithm, you can see the distribution as well as the type of plaque that is present. And here you can see how it outlines in cross sections relative to the CT image. So when you look at his total plaque volume, it was 619, which is in that severe stage. Again, what you're going to see is that he's more than that 80% non-calcified. But even though he's only got 3% low attenuation plaque, it is almost all in that LAD, which is concerning. But remember, I told you he has a family history. So you may want to go to that extensive stage of therapy. So he actually presented 6 weeks later for ongoing symptoms, and he had a left heart catheterization. And what I'm going to show is literally the CT demonstrated like 50 to 70% stenosis, maybe a little more significant, but the invasive FFR correlated well with the FFRCT, and the plaque assessment correlated well as well. So when you look, the yellow is non-calcified, the blue is calcified. You can see really how well it correlates with IVUS. So as we look at how we changed his medical therapy, we can say we maximized his statin. LDL was at still above 70, so Zeti was added, and they subsequently added a PCSK9. They intensified his blood pressure therapy. They added aspirin, and they worked on exercise and diet with this medication changes based off of the plaque analysis. So when I say you may have one opportunity, I think having one test that can tell you presence, absence of disease, tell you do they need to go to the cath lab or not, but also give you informed medical decision making on the plaque as well as what would be beneficial is so critical in today's world. But it's also critical to use these findings to show patients their imaging and show them exactly why their LDL targets are those. Because in the Gould registry, they found that there was an education gap with the patients, that we could potentially improve shared decision making and treatment adherence if we addressed it. So if we say the patient said that they were unaware of their risk, and they didn't know the reasons for lipid lowering therapy or what their LDL goals were. But where you could show them their plaque, then they can understand their disease burden. You can show them that chart and show them this is why your LDL needs to be this, and these are the medications that can help us to get there. Then they may be more compliant in understanding of why they needed those medications. Because we have to shift away from a probability paradigm to a certainty paradigm of what we're dealing with that is actionable, where we can look at our targets and look for residual risk. Because now there's a plethora of medications with improved cardiovascular outcomes. We have to shift our thinking, and we don't want this to happen where we have a total plaque volume of over 800 that doubles over the course of 3 years, where you go from non-obstructive disease to a patient requiring bypass surgery because of a left main stenosis. So when we look at plaque, what our goals are we don't want that plaque volume to grow, and we want to shift that non-calcified plaque and low attenuation plaque to calcified plaque. That's what our goals are. So with the DECIDE registry, what we found is that more than 50% just in the course of a short period of time had a change in their medical management, with 45% of those receiving a change having non-obstructive disease. And by decreasing the LDL, we may have a potential 10 to 15% improvement in cardiac risk events based on that LDL reduction. But we're going to track our outcomes in the registry as well. We do know that when you do changes in medical therapy based off CT, you have improved outcomes. What we're trying to change by looking at the Lancet Commission is how can we decrease cardiovascular death in 2050? And a lot of this is by changing our way of approaching things and by really working on behavioral as well as metabolic risks to improve outcomes. So we have to shift from late stage event management and only focusing on the obstruction and reactive care to thinking of this as a lifelong systemic disease with early detection of plaque and proactive risk reduction, where we can potentially standardize and address disparities to actually have a improved global impact longitudinally. So I hope this was very helpful to you, and that you will have a great success on your journey with plaque in the future.
Thank you so much, Dr. Rinehart. If you want to stop sharing the screen so we go into the Q&A. So this was amazing. I think the topic is extremely important, and we are here, very engaged in treating non-obstructive CAD, and I really think it can make a difference in patient care. So for everyone, please put your questions in the Q&A, and we'll go through them. Can you see me? Or can you hear me? I think your video went off. Let's wait 1 second for Dr. Rinehart. Can you hear me? Okay, I can't hear you back. So maybe try muting and unmuting, and then we can go through the Q&A. Thank you everyone for the patience. We're just having some technical difficulties. So there's a very good question from Dr. Anna Bornik. She asks, what are your thoughts about direct-to-consumer CCTA? Maybe I can start saying at least my point of view while we're waiting for Dr. Rinehart. I think like she showed, there's a very big discrepancy between what we see with CT and with risk factors, and the implications on therapy are huge. So I personally think that the patients have the right to know the opportunities for treatment. And when we look at people in higher socioeconomical backgrounds compared to what we see in the Bronx, for example, many people are getting CCTAs for assessment of plaque as executive assessments, or to evaluate the real risk. I think in my particular point of view, it's key what you do with these findings. It's key that you're not just stenting anyone if they have obstructive CAD. So when you're imaging asymptomatic, you need to see how the patient will feel with also finding plaque, what implications will have in their also mental health, and if they're willing to increase their therapies. But it can have a significant impact on the lipids, on plaque progression, and we're waiting on more data to see the impact on outcomes as well. But we all think that treating this non-obstructive CAD aggressively is the future. So let's see if Dr. Rinehart shows logs in again. And let's see if she's. Let me. There we go.
Oh, thank you. Yes, so I completely agree. I think as we're looking forward to what's going in the future, I think we have to start with asymptomatic patients and really prove the outcomes first. I think the Transform research trial is really going to look at the asymptomatic patients, especially with metabolic risk. So I think that trial, the last thing I heard was about 6,000 patients enrolled so far. So I think that will help guide us in that asymptomatic diabetes patient population. I think there is some data with the PAD patients with asymptomatic disease because they're overall high risk, that you could potentially use those. So probably the two most common reasons that we're clinically using in an asymptomatic patient population is probably preoperative clearance right now, as well as calcium scores over 400. So I think that we do have an asymptomatic arm within the DECIDE registry. So looking at those outcomes will be helpful. But I think, we have to prove all of the outcomes in the symptomatic patients first and await all of these trials in the future. But what I think is it's going to happen much more quickly than what we thought. Because who thought that plaque would be available and consumer availability this quickly? And again, when I get thoughts of, well, you don't have outcomes from DECIDE yet. Well, the reason the insurances are approving is because we showed a change in management where we're utilizing drugs with improved outcomes that are already proven. So I think that's why you're going to see a much more rapid escalation and approval of these things compared to potentially FFRCT early on.
Thank you very much. Yeah, that's a reason why in the non-obstructive statement we did it for patients with chest pain that Leslie was part of. And the idea was the same. Those patients are getting CCTA, many of them have non-obstructive disease, and that's a low-hanging fruit. I have one question for you on the follow-up CCTAs. So do you have in this registry people with follow-up CCTAs, or have you done that? And the question is, we see that, the plaque can progress like the patient you showed, but once you control, we can bring these LDLs to levels like you showed, like below 10 even, or very low findings. Do you see plaque progression still, or do you think we can halt disease?
Yeah, I think it's kind of interesting when you're looking at some of the patients. So I think there will be probably a subset of patients who have follow-up coronary CTs. We're going to be able to follow patients up to 5 years for their outcomes. So I'm sure we'll probably try to monitor if they had a repeat CT in the future. Um, but is that something we're directly trying to look at with Decide? No. But I think that will be a subject. But I think what we have to show is really good reproducible results with a plaque analysis. When you're doing follow-up studies, you have to make sure they're matched for matched. And that is going to be key. So I think while we're learning all about this, they're fine-tuning those at the same time. What I will tell you is from patients that I see with really controlled risk factors who are getting coronary CT and plaque is, so I had a patient with an LDL of 40 something the other day. What you see is, and they were on all the right medicines, the blood pressure was well controlled. What you saw was about a 40% calcified plaque compared to 60% non-calcified with zero low attenuation plaque. So that goes to show you when you start using the product and you have well-controlled patients as well as those who are uncontrolled, you really start to see that shift in the plaque towards calcium and not seeing that low attenuation plaque burden. So that really highlights what we're going to see in the future. And also we have trials like Evaporate, which looked at follow-up or sequential things with that one, for instance, was icosapent ethyl that really showed stabilization of plaque. So we're going to learn a lot about the plaque follow-up through these drug trials because CT is becoming one of the key endpoints for a lot of these drug trials as well.
Thank you very much. Yes, absolutely. So we have a question from an anonymous attendee. They ask, how do you compare softwares for plaque analysis, as there are quite a few in the market?
Yeah. So there are a lot of different plaques available. So one of the things that I look at is what is the research that's been done on the different types of platforms and what is the complete portfolio? Because I think it's hard in today's world to look at having multiple platforms for different products. So I try to look for the one with the absolute best evidence. And for me, having that IVUS controlled trial is very critical, but also having some reproducibility results going forward. So, and you have to really do your investigation because a lot of the claims aren't as big. But I think really having a platform that shows you how to use it effectively, but also again, to me, the gold standard for any plaque should be they have to have an IVUS comparison one-on-one in a randomized controlled way.
That's very important, I think, and we have plenty now, but we will have even probably more in the future.
Correct.
To stick to the ones that actually have data behind them, and the reproducibility analysis, I think, is key as well. I couldn't agree more. And we have a question from Rob Osfeld. He asked a question that I think we get quite a bit. So he says, thank you for your talk. In regard to being more proactive on imaging and prevention, what are your thoughts with vascular ultrasound versus CCTA? He says maybe even in the femoral artery.
Mm. Yeah, so even when we look at, for instance, carotid IMT compared to calcium scores, we know that it's very present. What I find, I use any type of imaging when I see patients, by the way. So the first thing I do when I see a patient is I look at any ultrasound report or I look at any CT personally, and then I can say, this is a minimum of what we need for you. and it tells me that we need more aggressive therapies. And I shoot for lower LDL targets just from that data alone, right? So you can use, whether it's ultrasound or CT or on a PE study or an abdomen and pelvis for abdominal pain. I do use that to help guide my therapy. But I think what we are very weak at is utilizing those imaging modalities that are already available, but really shooting to the right targets. And we're, even for our highest risk patients, we're not using all of the combinations of therapy or getting to the low LDL targets. And I think the PAD patient population highlights that very well, right? So this is the highest group people with what we showed was 44% mortality with total plaque volumes more than 750, despite being asymptomatic and no known heart disease. So, and a lot of those patients don't even get in to see cardiology sometimes, right? So I think it's really educating everyone on how to be more aggressive and look at the modalities. I think the plaque analysis, the exciting thing about it is, some people are saying, and I think Alan Taylor said this very well, in order to make changes, you first have to quantify the problem in order to act on it appropriately. And I think quantifying it and coming up with a methodology that's easy to follow is very critical to that. So that's why we came up with that management strategy, because we know our current methods aren't working. So how can we make it simple but allow you the autonomy to do what you want? We're just highlighting the goals that are appropriate for that plaque volume, but also all the combinations of therapy. So and sometimes I'm surprised even myself when I look at it, because like I was sharing that one patient who had an LDL that was at goal. I'm like, well, what could I do to improve that patient? And maybe it was shifting from Lipitor to Crestor with not many other changes, but just fine tuning things. And I think the cardiovascular metabolic medications are being way underutilized right now. So I think highlighting those as options for therapy is very critical, because even SGLT2 inhibitors, remember, every single patient that we see who has CAD is essentially a stage A heart failure, right? Because they have risk factors. So seeing beyond just the heart failure indication or the diabetes is important.
Thank you very much. I agree, Rob. I think the problem with, and this is my point of view, at least with ultrasound, is if you're only quantifying stenosis, like you get when you order a carotid or a femoral, you're missing the point. And the idea is that there are, I know, works in progress on using 3D volume quantification of this plaque on ultrasound. But that's not commercially available yet. So plaque in the coronaries, you can quantify, that's commercially available, that's reimbursed by the insurance. So I think as of now is the best we have. If in the future we can scan the carotids and do 3D volume assessment and quantify it, and we show that that's reliable, like we're talking, and that's good, yeah, that's going to be another option, I think, to have it. But we don't have that yet. So that's, I think, the problem. We have a question from Ahmed Abu Said. He says, can you elaborate how to use transgradient FFRCT?
Oh, okay. So the translesional gradient, FFRCT, is when you measure the FFR before and after a stenosis. So it's the delta. And if it's more than 0.12, it's considered significant. Now, this is one of the things I love about FFRCT versus other products, is it's not a binary yes, no answer, right? It can actually give you warning signs. So if you have a delta of, let's say, 0.15 across a proximal LAD lesion, maybe it has high risk plaque, but the FFRCT is still 0.82 or something like that. There's no vessel defined ischemia, but it's telling you this plaque is high risk of an event. So it tells the provider, number one, titrate the anti-anginals, get the LDL as low as possible, but have a low threshold to send that patient to heart cath if they're clinically still having symptoms despite that. I think if you look at it with high risk plaque as and also in the left main and proximal LAD, it's very meaningful in those three scenarios. With the left main, I don't rely solely on that FFRCT. For lesion specific ischemia, because again, it's a large vessel. You may not reach that absolute number of less than 0.8. So the delta is very important. So in the left main in particular, I always do an MLA of the smallest luminal area. And whenever it's less than 6.5, I think it warrants further evaluation so we don't miss those left main disease cases.
Thank you very much. Yeah, I couldn't agree more. And we recently published in acc.org an expert consensus or opinion on the use of CT in left main. I agree with you that has a lot of value. I think as a last question, something that I know many people are interested, if you could share maybe the flow of how you do commercial, plaque, or how does it work in your hospitals? Someone gets
Sure.
a CT, what happens next?
So I think there's different ways to approach it depending on where you are. I always like to start somewhat small and gradually build it. So when we were part of the Decide registry, obviously anyone with presence of plaque qualified, and we would send them. So since that has been completed in enrollment, we're switching to a commercial platform. So first of all, I found some of those same individuals who were on board with it anyway, because what you want to do is make sure that you're getting the approval through their insurance companies first. So, and so I wanted to start small, make sure I got the process worked very well. So, for instance, I chose a small group of people. And then I said, okay, we know from a Medicare standpoint, the severe stenosis greater than 70%, you're not supposed to send. So anything from 1 to 70% is viable. So we used our roadmap to really where it shows you those color gradients where yellow is mild, pink is moderate, purple is severe. So we kind of trained our technologists, okay, anything that's purple, that's severe stenosis, we're not going to send. That's excluded from the plaque analysis. To start small, we have those few number of physicians we're looking at, then we'll ramp it up. But I'm starting with the yellow and purple and the pink capsules where it's mild and moderate. Because I think when we talk to communities, the question of what the benefit was really in that CAD-RADS 1P1, right? Where it's just that minimal focal stenosis in maybe one or two spots. So we know those need probably a moderate intensity statin. So is the plaque analysis going to change much of that? So we decided to start anything with mild and moderate stenosis and those select group of patients. We're getting the insurance approval for those, and then we're reporting it out as a separate report later from downstream from our CT and plaque. So far, we've only had one denial, though, I will say, which is surprising. And hopefully that's how it's going to work going forward. So, and I think, again, the goal is to expand the clinical pool at that point.
No, that sounds very good. And it's what we're trying as well. First, you need to make the program sustainable, and then you can expand it after that. So it sounds great. So congratulations again on the amazing work you're doing, and thank you so much for spending time with us. And hopefully, this helps people in other hospitals how to learn how to get this into their system.
Yeah. Thank you for the opportunity.
Thank you. Bye bye.